Welcome to my session today on OSCE. Today we will talk about the OSCE on the thyroid gland. Okay, I shall go through the OSCE examination on the thyroid and then show you some slides, OSCE slides and discussion on those slides. Okay, in the OSCE stations of the thyroid, there are again two types of stations. One is the interactive station and non-interactive station. The interactive station, where you are asked to take history from a patient with thyroid problem and with the use of a standardized patient, and you're expected to get the detailed history from the patient. You'll be observed and assessed by the examiner, or you can be asked to do an examination of the thyroid on a mannequin. In the non-interactive station, you will be shown slides, pictures, videos, or specimens related to thyroid, and you'll be asked questions on the clinical features, diagnosis, investigation, and other aspects of clinical aspects of thyroid problems. And you can also be asked on the outline of the treatment of the problems that you are shown on the slide. Okay, here the first one is a patient. You are seeing Mrs. Ang, a 52-year-old woman, because she noticed a large swelling on her neck for the past 6 months. Take a focus history and perform a focused head and neck examination on Mrs. Ang. Okay, in this examination of history taking, first of all, the points to consider: clarify the location of the mass, the onset of the mass to the neck, progression in size, whether it's pain or painless, whether there is compression symptoms, dysphagia, odynophagia, or changes in the voice, and whether there are symptoms suggestive of hyper or hypothyroidism. Then systemic symptoms like weight loss, night sweats, anorexia, fever, diarrhea, past medical history, exposure to head and neck irradiation when young, exposure to tobacco, smoking, alcohol, and betel nut chewing, personal history of thyroid disease, family history of thyroid disease, and family history of head and neck cancer. Under the examination, physical examination, you are expected to introduce yourself to the patient, wash your hands, and briefly explain to the patient what the examination involves, and reassure him that it will be painless. Ask the patient to sit on a chair. Make sure there is sufficient space for you so you can access the chair from both front and behind. Then you go into the general examination, comment on the body status, assess for signs of obvious alopecia, vitiligo, signs of abnormal temperature regulation such as sweating or shivering, and obvious tremors of the hand. And you continue the inspection of the patient, comment on the location of the mass and any asymmetry of the swelling in the neck, comment on stigmata of hyperparathyroidism in head and neck, such as exophthalmos, lead lag, etc. Comment on the stigmata of hypothyroidism in the head and neck, skin and hair changes. Comments on size of the thyroid, and observe the thyroid as the patient swallows some water. On palpation, comment on the quality, size, and mobility of the mass. Comment on its hardness, irregularity, or whether it's tethered. Comment on the size of the mass, trees especially less than 2 cm in diameter. Palpate the lymph nodes, regions of the neck and head and neck. Name the regions which are being palpated. Comment on the size, texture, and mobility and location of the nodes that are identified on palpation. Ask the patient if palpation is tender. Palpates both lobes of the thyroid. Comments on size and nodularity. and auscultate the thyroid and comment the absence or presence of fluid. Then look at the patient's hands, inspect the nails and the fingertips for thyroid acropathy, and onycholysis, palmar erythema, fine tremors. Feel the hands and assess the temperature, the radial pulse, the nature of the pulse, vote for rhythm and volume. And these are some of the things where there's abnormalities with fingers short, and there is abnormality in the fingers, nails. Here, echo, friable, brittle fingernails. Looking at the eyes, proptosis, eyes and preorbital areas. Proptosis is unilateral or bilateral. Assess the ocular, extraocular muscle function for oculopathy. For the lid lag, and assess your convergence of the eyeballs. Moving your finger towards the patient's nose, ask the patient if it is painful or elicits double vision on focusing on the fingernails as it approaches his face. Then go on to examination of the neck in general, inspection, palpation from behind the patient as shown in this picture here. This is how you palpate a patient from behind. Palpate for the lymph nodes in the neck, feel for any tracheal deviation, and percuss down the sternum for any protrusion, extension or dullness. Auscultating the gland, look for whether there is decreased air entry, whether there is stridor, or whether there is any bruit in the neck. Then the legs should not be forgotten. Look for pretibial mixed edema. Elicit the patellar reflex. There will be hyper or hyporeflexia in functional disorders. Perform the sit to stand test to check for proximal myopathy, asking the patient to cross their arms and stand from the chair without using their arms for support. And to complete the examination, remember, if you have forgotten something important, you can go back and complete this. To finish the examination, stand back from the patient and state to the patient that to complete your examination, you would like to perform the cardiovascular examination, especially for atrial fibrillation or systolic flow murmur, and also not forget to take a blood pressure reading. Okay, this is the OSCE checklist for thyroid. Introduction here. Introduce yourself, all these basic formalities. Ask the patient to sit on a chair. General inspection. Nails, fingernails, palmar erythema, tremor, radial pulse, and the eyes, proptosis or exophthalmos, eye movements, lid retraction, and convergence. Okay, then palpate the thyroid. In examination, palpate the neck. Look for the thyroid gland size, symmetry, tenderness, and other lumps. Palpate for lymph nodes, tracheal deviation, percussion for retrocellular dullness, and auscultation of the gland and the legs for evidence of pretibial mixed edema. Patellar reflex and sit to stand test for myopathy. Thank the patient and close and complete the examination, inspect for evidence of gynecomastia, perform a cardiovascular and blood pressure readings. Okay, these are some features of thyroid disease: hypothyroidism, hyperthyroidism. Hypothyroidism, all the functions of all systems are reduced. And in hyperthyroidism, every system and every symptom increases function. Every system increase function. These are the features to suggest that is increased function. And causes of Graves' disease is a very common cause of hyperthyroidism, and these are the common symptoms or signs that you get in these patients. Okay, Next important thing for the examination is some special clinical tests on the thyroid. These are the list of common systems that are done, tests that are done: Pemberton sign, Berry sign, Cocker sign, Horner syndrome, Vizilow's method, Leahy's method, and Kreil's method. Okay, so these are all various special tests that can be done on a patient with enlarged thyroid. Okay. Okay, now I'll go on to show you a short video on the OSCE examination of the thyroid.
Hello there, my name's Andrew. I'm one of the final year medical students. Could I confirm your name and age, please?
Hi, I'm Simon and I'm 24 years old.
Nice to meet you, Simon. Today I've been asked to examine the thyroid gland in your neck. Would that be okay?
That's fine.
This will just involve me generally inspecting, then I'll move in closer to the neck to have a closer look, and then have a feel of the neck as well. Is that alright?
Sure.
That's great. Are you comfortable where you are?
Yeah.
Fantastic. We'll start. Simon, if you could just bring your arms out in front of you like this and splay your fingers. Fantastic. I'm just going to lay a piece of paper on the hands. If you could turn your hands over for me. Finally, I'm going to feel your pulse. Thank you. I'm now going to look more closely at your eyes. If you could just pick a point on the wall behind me. And now I'm just going to look from the side. And I'll now look from behind. If you could just look slightly up for me, Simon. We're just going to do some movements of your eye now, Simon. So if you could just follow my finger, do let me know if you have any pain or double vision. That's great. Again, if you could keep your head still and follow my finger for me. Thank you. I'm just going to more closely inspect your neck now. If you just stay as you are. And if you could just take a sip of this water and hold it in your mouth. And swallow. Fantastic, Simon. If you could just stick your tongue out now. I'm now just going to feel your neck as well. If you could just stick your tongue out for me, Simon. That's great. And if you could just take a sip of the water for me. And swallow. I'm just going to feel the glands in your neck. Fantastic, thank you. I'm now going to feel your windpipe. It might be a little bit uncomfortable. I'm now going to tap on your chest. And finally, I'm going to listen. If you could just take a deep breath and hold your breath there. And breathe normally. Simon, I'd just like to finish with some special tests. So we're going to start with the reflexes in your arms. If you could just relax your arms on your lap like this with your palms facing to the ceiling. Fantastic. I'd just like to look at your shins, if you wouldn't mind rolling your trousers up for me. Sure. Fantastic. And finally, if you could stand up, but first I'd like you to cross your arms for me. And relax. This completes the examination. Thank you very much. Today I examined Simon Sayers, who's 24 years old. On general inspection, he had a fine tremor of his outstretched hands, but there were no other peripheral stigmata of thyroid disease. There was no evidence of thyroid eye disease and no goiter. To complete my examination, I'd like to do some blood tests and look specifically at the T4 and TSH levels.
Okay, now we go on to some practice OSCE slides on thyroid problems. Okay, question number 1. This is a picture of a 32-year-old woman who presents with a swelling at the lower end of the neck on the right side. The questions: name the differential diagnosis for this condition. Adenoma, thyroid cyst, cervical lymph node, carotid artery aneurysm, or multinodular goiter. Question number 2. What are the investigations necessary for this patient? The answer: ultrasound scan of the neck and thyroid function test, which consists of T3, T4 and TSH, and fine needle aspiration cytology. The third question: outline the management of the patient. The answer is to confirm the diagnosis with the investigations mentioned and followed by thyroidectomy, either hemithyroidectomy or a lobectomy. Question number 2. This 29-year-old woman complains of a 1-week history of a painful swelling for the back of her neck, as shown here. It is about 1 by 1.5 centimeters in size and tender. First question: what is the possible diagnosis of this patient's condition? The answer: cervical lymphadenitis, possibly of infective origin. Name the investigations for her: full blood count, ESR, ultrasound on the neck, and biopsy or fine needle aspiration cytology. What is the treatment for the patient? Course of antibiotics, analgesics, and if it fails to resolve, then excision biopsy. Okay, coming to some common causes of swollen cervical lymph nodes. Common cold, okay, a lymph node in the posterior triangle here. Infections of the upper respiratory tract, infections of the ear, infections of the scalp, sore throat, tonsillitis, and ear and throat or mouth dental problems. Okay, all these can cause a posterior triangle cervical lymphadenitis. Question number 3. This is a 43-year-old man, okay, with fever, generalized lethargy, and weakness for 3 weeks. He notices swelling in the right side of the neck, in the upper part. He also has a swelling on the other side of the neck and both axilla. These were confirmed to be enlarged lymph nodes on clinical examination. What is the likely cause of the swelling? Answer: lymphoma, lymphadenopathy, or TB lymphadenopathy. Question 2. How will you confirm the diagnosis? Full blood count, ultrasound scan, and excision biopsy of the lymph node. Question number 3. How will you classify the cervical lymph nodes? Levels 1 to 7. Now, level 1 to 7 as shown in the next line. Okay, level 1, the submental and submandibular lymph nodes. Level 2 is the upper jugular lymph nodes. These are the deep lymph nodes, deep cervical lymph nodes. Level 3 is the middle jugular lymph nodes. Level 4 is the lower jugular lymph nodes. Okay, these jugular lymph nodes are the deep cervical lymph nodes. Level 5, lymph nodes of the posterior triangle. Level 6, the visceral lymph nodes, in the lymph nodes of the visceral space, where the thyroid is located. And level 7 is the superior mediastinal lymph nodes. Okay, this picture also shows you the various levels of lymph node of the neck. Question number 4. A 40-year-old woman complains of swelling in front of the neck. Yeah, diffuse swelling in front of the neck for 3 months. This was associated with palpitations, excessive sweating, and loss of weight. Examination reveals the findings as shown in these pictures. What are your findings on examination? The answer: a staring look, proptosis, flush face. Okay. What is your diagnosis? Thyrotoxicosis, possibly Graves' disease. Next question. Describe the test to confirm the diagnosis. Thyroid function test, which consists of T3, T4, and TSH levels. Ultrasound of the neck and thyroid. What will a TFT or thyroid function test reveal in this patient? Answer: there will be decreased TSH but a raised T3 and T4. On this slide, on the left, it shows the normal values of the various thyroid hormones that are felt. Thyroid levels. Here, total T4 and T3 and TH. Here will be the free T4, T3 and TSH. On the right here, it shows you the value of these thyroid function tests in some of the common conditions. In primary hypothyroidism or mixed edema, the TSH will be high, T4 will be low. In primary hyperthyroidism, such as Graves' disease, TSH will be decreased, the T4 may be normal or elevated, and T3 is usually elevated. And patients with poor compliance, thyroxine compliance, this is by taking exogenous thyroxine, the TSH will be high. The T4 may be normal or elevated, and T3 will be normal. So these are the patients to suggest that they are poor compliance to a treatment. Okay, primary hyperthyroidism, this will be the value of the T3, T3, T4 and TSH. Okay, another chart to show you the various levels. Normal, TSH and T4 levels will be normal. Hyperthyroidism, TSH will be low, T4 will be high. Hypothyroidism, high TSH, low T4, and secondary hypothyroidism, low both TSH and T4 will be low. Okay, as shown in this graph here. Next, question number 5. This 61-year-old lady has a large swelling over her neck for the past 10 years. Okay, there's a large swelling. What is your diagnosis? The answer, large multinodular goiter. Name the complications of this condition. Hoarseness of voice, stridor, and dysphagia. Okay, these are signs of compression. Next, hyper or hypothyroidism. Features of hyper or hypothyroidism. Third question, what are the features of malignant change in this patient? Sudden increase in size, onset of the 3 pressure complications, hoarseness, stridor or dysphagia, and sudden onset of pain. Fourth question, what is the treatment for this patient? Subtotal thyroidectomy with hormone replacement, with thyroid hormone, thyroxine replacement therapy. Question number 6. Figure 1 here is the picture of a 15-year-old girl with a lump in the front of the neck. Here, front of the neck for the past 6 months. It's painless, moves with swallowing and protrusion of the tongue. What is your diagnosis? The answer, thyroglossal cyst. Second question, what is shown in the second image on figure 2? Okay, this is figure 2. The second image, this is an ultrasound image of the patient. Ultrasound scan of the neck. What are the complications of this condition? Infection, abscess formation, sinus, fistula, and malignant change. What is the treatment for this condition? Antibiotics if it is infected, and excision of the cyst with the trunk, with the tract, thyroglossal tract, right until the point of origin at the base of the tongue. And this is known as the cyst trunk operation. Question 7. This picture is the surgical wound was taken a week after the surgery for a large multinodular goiter in a 50-year-old woman. Okay, this is the scar, transverse scar over the front of the lower neck. What is the most likely surgical procedure done for this patient? Thyroidectomy, either total or subtotal thyroidectomy. Name some complications, common complications of the operation. Bleeding, hematoma, infection, hypothyroidism, and hypoparathyroidism. Last question, what are the complications of a multinodular goiter? Pressure symptoms and malignant change. The pressure symptoms include hoarseness of voice, stridor, and dysphagia. Question number 8. These are histopathological images from a thyroid gland removed at right lobectomy for a large right lobe nodule. Okay. What do these pictures show? Plasma bodies, often any eye cells. Okay, these are often any eye cells, and these are plasma bodies. Plasma bodies, highly eosinophilic deposits in the thyroid. What is your diagnosis? Papillary carcinoma of the thyroid. What further treatment will you recommend for the patient? Total thyroidectomy with lymph node excision, level 6 lymph node excision, TSH suppression with thyroxine, and consider the use of radioiodine ablation of metastasis. Okay, now these are pictures to show you the histological features of some papillary carcinoma. Okay, these are samoma bodies, holes of tumor cells which indistinctly separate from one another. Holes, okay. Samoma bodies of dystrophic calcification, and these are the microscopic appearance of samoma bodies. And this is the often any eye nuclei. Okay, these are the often any eye. The eye look like the eyes of the often any. Okay, is seen in this diagram here. Question number 9. This is a chest X-ray of a 55-year-old woman with a large mass in the right lower lobe of her thyroid. She complains of being breathless on lying down here. Okay, this is the X-ray. What does the chest X-ray reveal about the lesion? There's an extension into the right mediastinum. That's from the lower lobe of the thyroid. An extension into the right mediastinum with deviation of the trachea over to the opposite side. What could be the patient's symptoms? Pain, breathless, swelling of the neck, engorgement of the veins of the neck and the face. These are features of thoracic inlet obstruction. What further investigations will you do for the patient? Chest and CT and neck CT scan with contrast enhanced to give you more details of the pressure symptoms that a patient is facing. What is the treatment? Thyroidectomy followed by radiotherapy or radioiodine ablation. Okay, these are 4 pictures, chest X-ray to show you a last protrusional extension of the thyroid with compression of the trachea, deviation to the opposite side. Okay, there's a mass here, large mass at the thoracic inlet, and which compresses the trachea here. Okay, compression symptoms leading to stridor. Now, protrusional extension of the thyroid. There are a few types. Plunging goiter, rise with deglutition, and then descend again through the thoracic inlet. So when the patient swallows, it comes up out of the thoracic inlet, and after that it goes back into the thoracic inlet. Next is a mediastinal goiter, which lie wholly in the chest but are connected with the thyroid and supplied by the thyroid vessels through a narrow band. The third group is the intrathoracic goiter, totally intrathoracic, lie wholly in the chest but completely separated from the gland supplied and is supplied by the mediastinal vessels. Okay, so there are 3 groups of them. This is the plunging type, where it goes in and out of the thorax. Mediastinal type, which accounts for 50% of them, more than 50%, is wholly in the chest, but blood supply comes from above, from the neck. And intrathoracic, independent and totally in the thorax. Okay, this retrotoral goiter arises from the lower pole of a multinodular goiter. Very few from ectopic tissues within the thorax, usually in patients with short neck and strong pretracheal muscles. Clinically, many of them are asymptomatic. If they develop symptoms, it's usually dyspnea at night with cough and stridor, dysphagia, and engorgement of the neck veins and chest veins, and these can be diagnosed by chest X-ray, soft tissue shadow in the upper mediastinum. Treatment is subtotal thyroidectomy. Symptoms of substernal or retrosternal goiters. These are the symptoms: stridor, difficulty in breathing, stridor, hoarseness of voice, cough, wheezing, presence of bothersome cervical mass, difficulty in swallowing, and positive Pemberton sign. Trouble, which is a difficulty in breathing, stridor, face, flushing of the face in certain positions, and especially when the patient lifts his arms above his head. Okay, this picture here shows you the percussion for retrosternal extension of enlarged thyroid is checked by percussion of the upper part of thorax on the affected side. And sometimes you can also get bruit over the area. Okay, bruit. So the percussion of the thyroid is very, very important. Percuss downwards from the sternal notch, that's the angle of Louis. There should be dullness which expanding due to the expanding thyroid mass into the retrosternal region, possibly retrosternal goiter. Okay, this is how you percuss. Question number 10. This 26-year-old woman presented with a swelling over the left side of her neck for 2 weeks. What is the procedure done on her? Okay, this is the patient, ultrasound probe. Okay, the examiner placing an ultrasound probe, and this is the ultrasound scan of the neck and thyroid. Question 2. The image obtained is shown in the right. In the second picture on the right, what does it show here? Okay, it shows a hypoechoic mass, which is well encapsulated in the left lobe of the thyroid. Outline the management of this patient: ultrasound scan, fine needle aspiration cytology, and followed by the appropriate thyroidectomy. Question number 11. This picture shows another similar procedure done on the thyroid. Okay, here again there's a probe here and a needle here. What is this procedure called? Ultrasound guided aspiration, FNAC or FNAB, biopsy. What are the indications for the procedure? Presence of a thyroid nodule or cyst, multinodular goiter, thyroiditis. These are the indications. Name the complications of this procedure: bleeding, hematoma, secondary infection, and if it is a tumor, dissemination of the malignancy. Okay, here again you see the probe here, the nodule here, and you aspirate. Question number 12. These are images of investigations of a patient with toxic goiter. What is the investigation? Okay, these are 4 scans here. Radioisotope uptake scan. Okay, this is the radioisotope uptake scan, RAIU. What do the images in A, B, C, D suggest? A is a normal thyroid. Okay, equally taken up, the radioiodine taken up by both glands. B is Graves' disease or hyperthyroidism, where both lobes there's increased uptake of radioactive iodine. This is multinodular goiter with features increased uptake, and this is toxic multinodular goiter. And D is a solitary nodule, which is hot solitary nodule, increased uptake, and this is a toxic solitary thyroid nodule. Okay, this is a normal one, equal uptake by both lobes. Graves' disease, increased uptake by both the lobes. This is an ultrasound picture showing you papillary carcinoma of the thyroid. See, there is heterogeneous material or substance within the nodule, and the capsule is not well, is breached. There's breaching of the capsule. Here, hypoechogenic, uniform echogenicity of the contents, and the capsule is well encapsulated. This is a thyroid adenoma, a benign thyroid adenoma. Thank you for joining me for this short session. Hope to see you again in another.